So we're fortunate to have Dr. Kinon with us, who's the chief of spinal neurosurgery at Westchester Medical Center and a assistant professor at the Westchester or at the New York Medical College. He completed his medical school at Indiana University, as well as a fellowship in spinal neurosurgery at Duke. And now he runs the spinal program at Westchester and is involved in comprehensive care of spinal deformity, minimally invasive spinal surgery, as well as trauma neurosurgery, which will be very relevant tonight. So Dr. Kinon, thanks again for joining us. So we're gonna have the first group go ahead and present Collins Hart and Sion Yu. So if you guys can share your screen and go ahead and get started.
Of course. Well, first of all, thank you so much, Dr. Kinon, for attending our seminar, and thank you, Michael, for having us. Just a moment, let me make the presentation here. So let me go ahead and introduce myself. I have a very extensive background. I'm originally from Finland. I'm a medical student from Finland, and I'm attending medical school of the University of Medicine and Pharmacy at Craiova in Romania, in Europe. And I'm planning to start initial residency in the United States upon graduation in 2025. I'm a third-year medical student, as in Europe we have a 6-year medical school program. And of course, I'm currently working on Professor Dr. Aurel Popa-Wagner lab and working on several review publications as well, as we discussed earlier with Michael Rallo. And I have a wonderful colleague from Sion, who probably can introduce himself as well.
Hey everyone, thank you for having me. I'm Stephen Yu. I'm a 4th-year medical student at Cooper Medical School. And it's glad to be here to discuss things neurosurgery.
Fantastic, fantastic. And I also want to mention that I'm a former concert pianist, and I'm a former champion, former hurdles my personal best was 51.3. And I attended University of South Alabama. I did my biomedical sciences and finance, and at University of Helsinki in Finland, I did molecular biotechnology. And now I'm pursuing medicine and interventional neurosurgery residency. So with that, I would like to start the influence of timing of surgical decompression for acute spinal cord injury, a pooled analysis for individual patient data. So basically, abstract background is that early decompression of the spinal cord injury, SCI, has shown positive results. And however, the urgency for acute spinal cord injury decompression remains unknown. And the goal of this research is to determine the long-term benefit of early and late decompression surgery for acute SCI. Abstract methods would be patient data was used from 4 sources during December 1991 and March 2017. We have 2 patient groups were formed early, less than 24 hours after spinal injury decompression, and late, more than 24 hours after spinal injury decompression. So we have first endpoint change in total motor score in the period of 1 year, and second endpoint will be changed after 1 year. So ACIA, impairment scale grade, is a change in upper and lower extremity motor is considered, and the light touch score of maximum 56 points and pinprick score of maximum 56 point is scale is used, and one-stage meta-analysis is applied, and secondary analysis is applied as well. And regarding ICA impairment scale grades, I just quickly wanted to show you an overview, and my colleague Sion will continue in a later slides. So basically we have a key sensory points for light touch and pinprick on both sides of right upper and lower and left upper and lower extremities. And of course, my colleague will continue with this grading scale. And but I think the key point that I would like to show is the motor scoring of 0 to 5, 0 mean total paralysis and 5 active movements, and sensory scoring would be 0 for absent and 2 for normal. And So basically, in abstract findings, there be used 4 data sets of 1,548 patients. 1,031 patients had spinal injury of 12 months after SCI. And it's a phenomenon that 528 patients had early surgical decompression. And that's actually lead to, and they had better neurological recovery. And then 1,020 patients that had late surgical decompression 12 months after SCI. So the patient had early surgical decompression. They had total motor score were 4 points higher, light touch score were 4 points higher, and pinprick score were 4 points higher, and even AIS grade were higher 12 months after surgery. And we can also see the same key points here. That's early surgery decompression patients had a higher higher points in total motor score, light touch score, pinprick score, and as you can see here, AIS grade as well. And so basically, in summarization, the key points from previous slides is put here, is in different picture. We have here, I would say grade 1 is a no centering function, grade E is a normal patient function. And as you can see, that's a patient that's had early surgery, decompression, have less no centering function, and actually they have more central function as grade involved, and for, I would say, 2 to 3% base. So in conclusion, the quicker, less than 24 hours, surgical decompression of acute spinal cord injuries performed, the better sensory motor recovery will be. And for optimal neurological recovery, decompressive surgery of acute spinal cord injury should be performed within 24 to 36 hours after accident. And basically the same context in a different pictures. As you can see here, we have a motor score declining here, and then it's remained the same, and it declines here at the level of 24 to 36. You can see 24 to 36 hours, and then it's remained the same. And that is why 24 to 36 hour windows are very important. And that is basically changing total motor score by time of surgical decompression. And here we have a density plot of frequency distribution of time. And as you can see here, 24 hours declining, and 36 hours, it's a very important window here as well at the cohort density. And so basically, in introduction, acute traumatic spinal cord injury is a catastrophic emotional economic burden to patient families and society. It involves paralysis, numbness, loss of bladder, bowel control, and treatment options. There's only a few treatment options. Unfortunately, targeted blood pressure management, so steroids of methylprednisolone that has anti-inflammatory properties, help reduce swelling, minimize the amount of damage, and spinal cord decompression, as I mentioned previously. Urgent surgical decompression would be restore spinal cord blood flow and improve perfusion to the semipenumbra and mitigate secondary injury. And according to experimental animal models, superior neurobehavioral outcomes are associated with early spinal cord decompression, and importance of urgent surgical decompression in acute SCI needs to be updated into clinical guidelines to inform better practice. And I think it's very important to conclude here that in research context area, that's evidence before study, where a rigorous analysis of this continuous effect of time to decompression on neurological recovery from acute SCI is needed, and few studies have examined thresholds for early or late surgery of less than 24 hours after spinal cord injury. Added value of this study provides clear evidence of the benefit to neurological outcome with surgical decompression done with 24 hours of acute SCI. Well, we do know that time is money in this context. Time is spine. Our first 24 to 36 hours after SCI is a crucial period of opportunity where a shorter time to decompressive surgery could augment neurological outcomes. Even within 24 hours of SCI, earlier surgery is associated with better outcomes, and undue delay to surgery should be avoided. And it's very important to pay attention on implication of all available evidence. Evidence indicates that surgical decompression within 24 hours of acute SCI is associated with improved neurological recovery, and data indicate that the benefit of early surgical decompression might persist up to 36 hours after injury. However, patients with multiple trauma and medical comorbidities might not be amenable to safe surgery within 24 hours, and clinical damage is required. And I ask Sion to proceed. Thank you.
Okay. Yeah. So thank you, Colin. So, for any good paper, there's the importance to analyze their methodologies. So for this study, there were 4 prospective spinal cord injury data sets that were collected and combined for analysis. And so the first one is the National Acute Spinal Cord Injury Study. So I listed these by chronological order. So this was a study from 1991 to 1995. So is one of the older studies. So this included 499 patients at 16 different centers, and patients were, and the primary outcome of the study was looking at different dosage of steroids at different time periods and whether that had an outcome on the patient effect. So the second is the SIN trial from 1992 to 1997. So this one included a total of 760 patients with either cervical or thoracic spinal cord injury, and patients were randomized to either ganglioside or a placebo, and this is across 28 North American sites. The third data set was the surgical timing in acute spinal cord injury study, and this was a more recent study from 2002 to 2009, and this directly compared patients operated on within 24 hours or greater than 24 hours was the primary outcome analysis, and this included 313 patients with cervical spinal cord injury before or after 24 hours, 6 different centers. And lastly, we have the North American Clinical Trial Network. This included 11 North American institutions in which they collected data on all patients with spinal cord injuries that had undergone decompression. And to summarize the study, again, here's the table. And the study took place, this study took place from 1991 to 2017 and includes all 4 centers. So next page, please. So the method, so we're talking about inclusion criteria, right? So the inclusion is that all patients with acute spinal cord injury at any level, so that includes cervical, thoracic, or the lumbar region, that underwent surgical decompression. And when we talk about the indication for surgery, this was very center specific. It was up to the individual center and the individual surgeon. But in general terms, patients that underwent surgery were deemed to have non-recoverable neurological status by conservative measures, or they had demonstrated a progressive neurological deficits. And more importantly, this study is non-randomized, and a lot of it was based on the selection of the individual surgeons. So it's important to know that. So next slide, please. So the primary outcome is the endpoint is the change in total motor score at 1 year from baseline based off the ASIA scoring. So the secondary endpoint was the ASIA impairment from baseline to 1 year assessment. Furthermore, the motor score, instead of the total motor score, the motor score was divided into upper and lower extremities, as well as sensory, such as pinprick and light touch. And most importantly, the study noted was very unique to this study because of the increase in sample size, was that they were able to analyze neurological recovery as a function of a continuous time interval rather than a dichotomous time interval between first 24 hours or later than 24 hours. This study actually breaks down the time interval into each individual hour, try to see what is the optimal time interval and what is the latest time interval you can have to have some neurological benefit from decompression. So furthermore, subgroup analysis were conducted in patients younger or greater than 50, different mechanism of injury, ASIA grade, and use of steroids. So we can, next slide, please. So as Collins already mentioned, so I just want to briefly touch on this again. So the primary endpoint was change in motor scores, right? So a motor score is divided into upper and lower extremities. and the total motor score you can have is 50, and the total lower score you can have is 50, therefore for a sum of 100. So the maximum total motor score a patient can have is 100. So this was measured at baseline and also 1 year follow-up. Additionally, light prick as well as light touch and pinprick were also assessed, and they included 56 on each side for a total of 112 on total for light touch and 112 for a pinprick. So next slide, please. And again, so furthermore, another secondary analysis was conducted looking at Asia grade change from baseline and 1 year follow-up. So next slide, please. So statistical analysis, again, to really analyze this study, you have to look into some of the methods, right? So a problem, with any prospective trial is that there's the missing data due to follow-up, right? That's a very common thing. So the study tried to address this limitation by two different methods. So there were patients with 1 year data. So if the patient did not have 1 year data follow-up with their motor score, their 6-month follow-up data, if they had it, was used as a proxy for their 1 year follow-up data. And this method is called last observation carry forward approach. So the question is, what if the patient does not have the 1 year follow-up data nor the 6-month follow-up data? In that case, our Markov chain Monte Carlo methods, which essentially is a sampling method that best predicts the 1 year outcome data, was used to fill that data. Additionally, because the increase in sample size, differences in baseline characteristics that could possibly confound the results of our what we're studying, are they're being adjusted in our study. Using the one-stage meta-analysis, they were able to adjust for baseline score based on baseline injury score, age, mechanism of injury, Asia grading, spinal level of injury, as well as steroid use. And lastly, they used a sensitivity analysis to include or exclude those patients with or without 6-month and 1 year data. So would you show the table, Colin, please? Here again, it shows you that in the second column, there were 311 patients that had missing 1 year data. They were filled with the 6-month data as the 1 year surrogate. And in the last column, there were 206 patients that did not have 6-month or 1 year data motor score follow-up, and instead they were using the Monte Carlo methods to fill that limitation. So next slide, please.
Yes, and as far as results are concerned, we had 4 data sets of 1,548 patients. Average age was 39 years old, and 528 patients had early surgical decompression 24 hours prior to SCI accident, and 1,020 patients had late surgical decompression 24 hours after SCI accident. Outcome data were collected from 1,031 patients 12 months after accident. 311 patients had 6-month score for imputation. 206 patients had no 6-month score and 12-month outcome data. Primary analysis where on patient with early decompression surgery had greater improvements at 12 months of follow-up, and sensitivity analysis where 2-stage meta-analysis showed improved essentially more recovery. And as far as subgroup analysis are concerned, unfortunately, it didn't reveal significant change in total motor score. And finally, secondary analysis, steep decline in total motor score, improvement with increased time over first 24 to 36 hour follow-up following injury. And as you can see here, a total motor score points were increased in early surgery decompressive patients of several digits. You can clearly see that early surgery side is favorable here, and a light touch score as well. There's a significant increase in the points of early surgery decompressive patients. And you can see here in pink prick score, the same scheme. The early decompressive surgery patients have higher points, and it's favored early surgery. And AIS grade of early surgery patients have as well increased points. And Sam, would you like to continue? Oh, and here is the result, secondary analysis. We can clearly see that 24 to 36 hour window is very important since the steep decline in total motor score improvement with increased time over first to 24 to 36 hours following injury. And yes, Sam, please continue.
Yeah, so thank you, Collins. Yeah, so just in terms of discussions, right? So what are the strengths of the study? And some of the strength is that this is a prospective study across 4 different cohorts. So this included centers from Europe, Canada, and America, right? So it's very generalizable, the study. And the study had a very large sample size. And because of that sample size, the different meta-analysis methods were able to be used to adjust for difference in confounding baseline characteristics. And most notably, the paper highlighted was the baseline injury severity. They were able to control for that. Another strength that is the long-term follow-up. Over 1,000 patients or have 1-year follow-up data. So therefore, it makes this study very reliable. And additionally, there was the uniform approach to handling of the missing data. So all the data were pulled together and all the data were handled according to some of the method I had addressed in the earlier, and the statistical modeling and adjusting for confounding variables. Lastly, when we talk about which also very unique to this paper was that this paper delineated the time interval on a continuous scale, which makes you think that early decompression is the best, right, within the first 24 hours. However, if you cannot do that, the 24 to 36 hours is also very important. And I think that's something that the literature had not previously described. And because of this surgical decompression versus continuous time interval, he was able to find and elucidate that important finding. So next page, please. So as with any study, there's a lot of some limitations that come with it. First of all, is the non-randomization of the study in a sense that there's a non-randomization of whether someone's getting early decompression versus late decompression. And because this is done across different centers without a strict criteria or indication for decompression, there's the introduction of selection bias between surgeons. Additionally, although the data spans almost 30 years, which gave us a very high volume of patients, there are limitations in terms of learning curve. There's limitations in terms of how we imaging these patients that have gotten better over the years. And there's limitation in different surgical techniques that have come about within the more recent years. And there's also increasing in the better medical management of these patients that we have. So all those things cannot, unfortunately, be analyzed in this study. Last 2 points include that the primary endpoint was looking at the motor score. However, the neurological motor score does not necessarily correlate with functional scores. Just because patients are getting better on a motor scale does not necessarily translate that they're getting better on a functional level. There hasn't been any data to suggest that so far. The same thing goes with the quality of life, right? So if patients are getting better at a higher motor score, if they're getting decompressed within the first 24 hours, it does not necessarily mean they have better quality of life. So those 2 questions, the functional outcome as well as the quality of life, need to be further addressed in future studies. And lastly, when we look at the ASIA scoring as well as the motor assessment, Colin, would you mind pressing the slide for me? Especially when we talk about early assessment of these patients, right? If those patients are getting decompressed within the first 8 hours or 12 hours, we know that patients can undergo spinal shock. And therefore, the ASIA scoring as well as the motor scoring might not be completely accurate, because if you had given these patients more time, they could have spontaneously recovered without the surgical intervention. Therefore, that further confounds our data. So in conclusion, on the next slide, please. So in conclusion, what we have shown, the paper has shown is that surgical decompression is ideal within the first 24 hours, as it is associated with superior sensory and motor function recovery at 1 year. However, if 24 hours cannot be achieved, the next window, which is the 24 to 36-hour window, is critical. At that point, that is a reflection point where surgical intervention can still result in meaningful motor and sensory function gains. So these findings have very important implications for for the management and guidelines of spinal cord injury, as well as for healthcare policies in terms of reimbursement for patients and surgeons, maybe on the time interval levels that could really impact the healthcare, the care of patients with spinal cord injury for the better. And with that, I just want to thank everyone. I want to thank Collins for everyone listening.
Yes. I would like to thank Sion, and I would like to thank our co-host Michael Bravo and Meredith Kinon. Thank you so much, and for cooperation. And here are our references. And thank you.
Great job. I mean, that was That was quite informative. So, I mean, I have a couple of questions. Maybe Colin and Sion, you can shed a little more light on this. So, with spinal cord injury in these patients, were they looking at like central cord, because central cord's handled differently by different physicians? Were they looking, was that included in this analysis, or what type of injuries were they looking at?
Well, I would say that was overall, spinal cord, of course, was included, but it was a general research conduct, and I would say that's, for example, ASIA impairment scale was in a major role here as far as motor sensoring scaling and sensory scoring is concerned, Dr. Kinon.
Yeah. So
Yeah, because it would be. I'm sorry about that. Yeah, go ahead.
No, I was going to say follow up with Collins is saying. So I think they essentially took all patients with spinal cord injury. I don't think they specifically delineated the different causes, and that's the point I made with the research spanning over 30 years, right? They even mentioned that initially, right, if patients are getting injured in the 1990s, they were probably complete core injuries, right, secondary to the airbag not being fully functional, CBL policies, right? Where you look at the most recent data from 2017. You're probably going to see more patients with spinal cord injury secondary to with the most common cause, which is central core. So I think they include all those patients across.
Yes, that's
it would be interesting to see, because this is a database it's a database research study. If they were able to get more granular and parse out, specific areas of where the spinal cord was injured, the type of injury patterns. Because central cord it's a spinal cord injury, but it's handled very differently between different surgeons. Even today, I mean, a while back with central cord syndrome, those patients would come in with terrible cord contusions, maybe not, a fracture dislocation, but just terrible cord contusions from severe cervical stenosis after a fall. And they would basically sit in the hospital, and over the course of several weeks or so, their motor function would improve, the neurologic function would improve, and then they would get decompressed. But with better anesthetic techniques, better understanding of the disease process, studies done by Dr. Failing's group, talking about earlier decompression, they're being handled differently, but it's still a very, I would say, surgeon dependent treatment. The other thing that I wanted to ask, did they, I guess they probably did not specify the different areas of the spine and whether or not they use different surgical techniques, like, is it time to decompress? Was it decompress and fuse? Could you explain that a little bit?
Well, they did not specify any different surgical techniques. However, they were very general, as Sion just mentioned. But of course, we can dig more into the data and look into their references as well, if necessary. Dr. Kinon.
Yeah, I believe they didn't, and I think in the methodology they also mentioned that they were, the indication was very loose. It was essentially anyone with neurological deficits that were not, that were either plateaued or they're getting worse, and they didn't mention specific of the techniques. It just said, all patients that had any spinal cord injury, any level that underwent decompression was the inclusion criteria.
Now, did they also ask about, or did they also tell about patients that had complete injuries, what their initial ASIA score was and whether or not they received treatment? Because I know patients that are complete, we handle them very differently. Usually if it's an incomplete injury, at least in my personal practice, I'm very aggressive with them. I'll take them to surgery and try my best to, fix the problem in an extremely timely manner. However, if they're a complete injury, then the type of surgical procedure and the timing is vastly different, because if they have no motor sensory function below the level of the lesion, they're going to be taken to surgery basically for nursing care purposes, right? Unstable spine, complete spinal cord injury, you're not going to make them better, but they have to be able to be stabilized in order for them to be sat up in bed, get pulmonary toilet, have the nurses take care of them, move them around so they don't get bed sores and that sort of thing. So did they talk about the proportions of patients that were complete injuries that were operated on and the type of improvement?
Well,
Or
well, I'm sorry to interrupt. Well, Dr. Kinon, they did not differentiate between incomplete and complete SCI. However, it was very generalized study analysis, and as Sian and I mentioned previously. And but of course, if you would like us to, we can dig more into data and previous references if necessary.
no, that's okay. It's just thoughts for discussion. But I thought this was a really well-written paper. I enjoyed learning about it because a lot, as both of you two have said, a lot has changed over the past 30 years. And Sion put it very nicely. Surgical techniques have gotten better. Nursing techniques have gotten better. Understanding of the disease process. How you mentioned earlier in your presentation, where, how do we treat spinal cord injury? Do we give them steroids? That was a hotly debated topic not too long ago, whether or not we treat spinal cord injury with a large dose of steroids, and then the timing, and
Yes.
it's been shown that steroids, actually do the opposite of helping patients with spinal cord injury. They make them worse because they set them up to getting infections. Their blood sugars are very elevated due to being on the steroids, and the anti-inflammatory effect and helping the swelling in the spinal cord and reestablishing blood flow and that sort of thing. I mean, yeah, maybe it does help a little bit, but really clinically it's insignificant. What's been shown more is aggressive blood pressure control, aggressive medical management of the other issues to perfuse the spinal cord, and timely surgical intervention helps in patients that can withstand surgery and would benefit from it.
Of course. Well, thank you for your feedback, Dr. Kinon. We really appreciate it with Sian.
Well, I thought both of you did a wonderful job. So.
Well, thank you so much, Dr. Kinon.
Yep,
And thank you so much, Sian, as well, for
Yeah, thank you.
cooperation.
Appreciate it.
Thank you.
Awesome. Nice job, guys.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.